to be moderating our second session, Shared Vision, Intersectional Experiences of Disability. And I'd like to welcome our first speaker, Leah Smith. Leah Smith is the Associate Director of the National Center for Healthcare and Community Living for People with Disabilities. And her talk is entitled Challenging Ableism in Medicine, Implementing Intersectional Self-Assessment Tools for Systemic Change. Leah?
Thank you so much for having me. Let me get my slides started. So, challenging ableism in medicine, implementing intersectional self-assessment tools for systemic change. Again, my name is Leah Smith. I have chin-length blonde hair, green glasses, and a black top. I don't have any disclosures today. So as director of the National Center for Dignity in Healthcare and Community Living for People with Disabilities, we have 5 partner organizations, Autistic Self-Advocacy Network, Morehouse, then Georgetown University's National Center for Cultural Competence, Maryland Center for Developmental at Kennedy Krieger, and then of course, Cincinnati Children's. So what do? We aim to identify and address inequities in healthcare and community living for people with disabilities. And we base our work on the 10 disability justice principles that are listed here: intersectionality, encouraging leadership by disabled people, resisting normative capitalist production, engaging with cross-movement solidarity, valuing wholeness, pursuing sustainability, fostering cross-disability participation, normalizing interdependence, understanding access as a collective effort, and cultivating collective liberation. So those are the 10 principles that we base all of our work on as we try to address and identify and address inequities within healthcare and community living. And we have intentionally very broadly defined healthcare and community living because we believe that there's a lot that goes into healthcare, not just the building, right? If you don't have access to transportation, then you don't have, you can't get healthcare. So there's a lot of different systems that go into place with that. So overall, our goal is to be disruptive, and that's what we have aimed to do with some of the work that I'm going to be telling you about today. But a little bit of background, some of the health inequities that people with disabilities experience. First, there's some key findings that 4 in 5 physicians believe disabled people have a worse quality of life. There's been a couple of reports that come out. It looks like this is a little bit, I don't know what happened with the font, so I'll just read it. But it's been 20 plus years since the Surgeon General's Closing the Gap report. And then COVID-19 exposed disproportionate morbidity and mortality. And then health inequity model is the cascade of disparities. That model specifically illustrates how for people with intellectual disabilities specifically have multiple social, environmental, and health-related disadvantages that compound over time to create severe health inequities. There's also intersecting marginalized identities to compound disparities. So if you are disabled, Black, and female, let's say, you're going to have a different compounding disparities rather than if you were just disabled, white, and male, let's say. So, and then further, there's structural ableism that's embedded within our healthcare system. Some of that structural ableism, as we know, are policies, physical barriers, and inaccessible equipment. So that looks like things like, as was just mentioned, a lack of training, discriminatory triage protocols, and systemic neglect. And then, of course, like physical barriers such as inaccessible scales, height and weight scales. So knowing these are some of the health inequities, we have developed, well, there's a lot of talk about resilience, first of all, and we like to talk about cripping resilience, which is not about overcoming disability, but resisting ableist expectations. And so as a result, our center has developed two self-assessment checklists. The one on the left is for healthcare providers, and the one on the right is for community support staff. In developing these, we had 5 assessment domains: awareness and knowledge of health disparities, communication, like AAC, language access, health literacy, quality of care, such as cultural humility, informed consent, data collection and use, patient portals, research, etc. And then advocacy, such as Section 504, addressing ableism and policy. So those are kind of our 5 assessment domains. And then each domain addressed intersectionality like race, ethnicity, language, gender identity, LGBTQIA, and socioeconomic status. So in developing this, this is just kind of a sample page of some of the questions that we ask. This one's specifically for healthcare providers. I provide information to members of healthcare teams that help support communication approaches that best meet the abilities and needs of the person, including, and so you can kind of select A, I do this frequently, B, I do this occasionally, and C, I rarely or never do this. And so this is how the self-assessment checklist goes. In implementing this, we partnered with we piloted, I'm sorry, with 8 organizations, 4 healthcare providers, 2 UCEDs, which are university centers, and 2 centers for independent living. So we went from co-design to pilot testing to a feedback loop to dissemination efforts. So what are the implications for disability justice that I mentioned at the beginning were the practical tools for advancing health equity? It shifts the focus from the medical model to a justice-oriented framework. Medical model tells us that people are in need of being fixed. Centers multiply marginalized experiences and addresses structural inequities in healthcare. So some of our recommendations from this have included integrating into professional education curricula, the checklists, require organizational equity assessments, support community organizations as leaders, and center lived experience and policy development. Some of these sound easy, but might be more difficult in practice. So we did face some barriers and identified in piloting this checklist. Of course, there were some time constraints. There was a lot of institutional resistance that we received. We also experienced some administrative resistance to intersectional frameworks, and there was some need for accreditation and or continuing education credits as we did this. So this checklist was we are funded by the Administration for Community Living, and we began this grant funding with this as one of our deliverables under the Biden administration. And then unfortunately, when the administration changed, we a lot of course, the terms changed, I guess I should say. And so we need to really acknowledge what happens when evidence-based equity terms become politically restricted. And so unfortunately, what has happened is we have not been able to publicly put these out any further past the piloting stage because of the changes in administration. So while we're really excited to get these out, they are currently being blocked for some of the equity-based terms that have been used. So we are, if you would like to request this checklist when it's available, I would encourage you to check or to take a picture of this, and then you'll have a link and we'll add your name and email, and as soon as it's out, we'll be sure to give it to you. In the meantime, feel free to follow us at Think Equitable and check out our website at thinkequitable.com. Thank you.
Thank you so much, Leah, for that great presentation. We'll move on to our next. It's a joint presentation by Athena Sofides and Allyson Hughes. Athena is a first-year doctoral student at Yale's Joint PhD program in American Studies and Women, Gender, and Sexuality Studies. And Dr. Hughes has lived with type 1 diabetes since 1995 and is an assistant professor at Ohio University Heritage College of Osteopathic Medicine. Their presentation is entitled Diabetes, LGBTQ Identity, and Healthcare Experiences and Struggles, Lessons from a Mixed Methods Ethnographic Study. All right, hand it over to you all.
All right, thank you so much, and good morning, everyone. I am just pulling up my slides now. So, as I said, thank you for joining me, and thank you for your support. So, first, I want to say that this project is really a passion project for Athena and I, and I'm so excited that we get to share our results with you today. So we will be talking to you about diabetes and LGBTQ plus identity and healthcare experiences. And we took a unique mixed methods approach. So I just want to start out with we have no disclosures at this time. And for the learning objectives, we want you to understand a little more about diabetes and understand more about gender and sexual minority health and what that looks like when it's combined and occurring for the same person. We're also going to identify themes from Athena's amazing thesis that was exactly on this topic. And we're going to explore clinical implications based on these findings, but also we're going to get a little bit into methods and really talk about mixed methods research and really how it can open up a new world, so to speak, of characterizing and prioritizing people's voices in research and policy. So first, I want to tell you a little bit about diabetes prevalence. As you all know, diabetes is very, very common, not only globally, but also in the United States. As of the most recent data that the CDC just put out in the last month, there are about 40.1 million people in the United States that are living with diabetes. Now, this includes folks who are actually diagnosed, and this also includes folks that are undiagnosed, which is very, very common. And often diagnosis does not happen until a complication occurs, or maybe a feeling of neuropathy, losing feeling, or a vision change, things like that. So there are about 830 million people globally, according to the World Health Organization. It's very likely it's more around the 1 billion mark at this point, but it's just important to know that by 2050, we're expecting these rates to double globally. And diabetes is a really important disease to think about in the way and under the umbrella of disability. Just know for this perspective and for the sake of this conference and this focus is that many people with diabetes, believe it or not, do not identify with having a disability and do not identify with the needs for accommodations, not only in the workplace, but also at school. So there's very much a disconnect when it comes to community resources and also finding social support. And much of the work that is out there is very anecdotal, which is why Athena's work is so important. So around 9.3% of the US population is a gender sexual minority, so GSM for short. And people with type 1 diabetes are more than 5 times more likely to identify as transgender and gender diverse than the general population. And so this really led us to thinking more about what does this work look like and what does this population look like? And what does it look like for folks who were diagnosed as kids and then are GSM and wanting gender affirming care? What does it look like for folks who are elder in the community and developing type 2 diabetes or even later in life type 1? There's really not any information out there beyond higher risk factors due to minority stress causing type 2 in folks who are GSM. So I am really a guideline nerd. I love health policy, and I always like to say, okay, we're saying one thing, but we're doing another. And so in the case of diabetes, and in the case of so many conditions around the world, we know that we have this great treatment, but it's very expensive. Diabetes is one of the most expensive conditions in not only the United States, but also globally. The cost of insulin, as we all know, is really hard to comprehend based on its very low cost to produce. And so you'll see, I'm sure, federal caps that are proposed and don't get passed. You'll see all kinds of coupons, and there's some very interesting things around cost for diabetes. But no, it is very expensive. And people with diabetes are also much more likely to develop comorbidities, so additional conditions across the lifespan. So really, no matter what time or age or who you are, you're more likely to have multiple conditions, and also, of course, polypharmacy with diabetes. So there's really a lack of clinical training around diabetes, but more so also for folks who are LGBTQ+, so GSM. It's very much, there is truly nothing. You can go to the American Diabetes Association Standards of Care. They're published every year, and they're also updated annually. And unless something more significant comes out treatment-wise, and then it'll be quarterly. But there's nothing, not a single word about gender-affirming care or supporting the GSM community. And so where we come in and think about this is we think about, what do health disparities look like? And what are we doing to promote healthcare for these folks if there's not only very limited training in diabetes, and that's all very limited overlap with disability, but on top of that, there's now this additional, the intersectionality of folks who are experiencing all these things at one time. So for this hypothesis for the study, GSM people with diabetes experience heightened discrimination and barriers to care at the clinic. They also experience identity-related stressors that complicate blood sugar management. Very much in diabetes research, it is very centralized on, we have to talk about blood sugar management, which is very important. But there's also so much more mental health-wise about diabetes. There's diabetes distress, there's depression, there's anxiety, there's all these things. But it's really key to really dive in and also talk about blood sugar management, because it's bi-directional, and everything mental health-wise impacts diabetes, and then diabetes impacts mental health. So for the methods, there were 3 ethnographic semi-structured interviews with GSM adults with diabetes that then informed the survey design. And interviews were recorded, transcribed, and then thematically analyzed by 2 trained coders. And themes from interviews then informed the survey. So it's important to know that this data was coded in Excel, and also the quantitative data was analyzed in SPSS. So the Qualtrics survey was distributed via purposive and snowball sampling, so chronic illness and GSM affinity groups, and 45 GSM adults with diabetes completed the survey. So for demographics, for age, we had it for age groups, and it was 11 participants 18 to 34, 13 35 to 54, and 18 55 and older. For race, it was, as to be expected, 88% white, due to this being online and snowballing sampling, and then for ethnicity, 7.1% Hispanic. So 9.5% of participants identified as transgender. And for education, it's important to know, as to be expected with this type of sampling and the way theses often turn out, and dissertations as well, is the majority of the sample were very well educated, where 11 had a bachelor's degree and 20 had a graduate degree. Okay, and at this point, I'm going to turn it over to Athena to talk about our lovely results.
Thank you so much, Allie. And hi, everyone. Thank you so much for having me. I'm just going to pull up my slides. Can everyone see the slides?
Yes.
Okay, great. So now we'll get into some of the results and conclusions from what Allie mentioned. So the first key result is that discrimination and stress adversely impact the experience of diabetes. Oh, excuse me. Let me go back. Sorry about that. So as Ali mentioned, this study was very non-representative as far as race and trans and ethnicity groups being represented. But even given this mostly white and educated sample, 81 participants reported having experienced discrimination, which underscores how much discrimination that is, at least in part, identity-based this group perceives that it's experiencing. Participants also ranked how health and life were impacted by diabetes and or other chronic conditions that they may have noted in the study, as well as on their medical treatment. And some of the notable ones for this group of GSM people with diabetes, especially the factors of daily stress and diet, were highly impacted. We also found that diabetes distress makes it harder to feel comfortable or safe in one's own body, which is a common experience for many gender minorities, including non-binary and trans people who experience gender dysphoria, and vice versa. So a feeling of being hyper aware of your body due to your chronic illness and the high degree of daily maintenance and engagement with the body that a disease like diabetes often has, and the experience of discomfort in one's body that can come with dysphoria. Many folks that we spoke with noted a correlation between these, and one seemed to trigger the other. And also we found that given those people who have intersectional identities, whether it's they have other chronic illnesses or disabilities, they're BIPOC, Black, Indigenous, people of color, or of low economic status, socioeconomic status, or otherwise have an intersectional identity that's affecting other aspects of their life, those folks tend to link those experiences together. So throughout this half of the presentation, I'll draw from a couple of quotes directly from our participants that illustrate some of these themes. So one person said, "Being chronically ill, I depend on my doctors in a way that most people do not. However, my queerness has put up a wall between myself and most of my care team. Most of my doctors try to at least use the correct name, but they still frequently misgender me and overall don't seem to understand or care to understand my gender identity." Another person said, "For trans people, it can be hard to feel embodied a lot of the time. Having a reason that you feel dissociated from your body, like diabetes, will exacerbate that." The next big result was that healthcare providers tend to lack knowledge about gender and sexual minority specific healthcare in general, and then its particular relationship to diabetes and to people with diabetes. And they also tend to lack often the cultural sensitivity to make many gender and sexual minorities with diabetes feel comfortable enough to continue to seek the treatment that they need or to initiate certain kinds of treatment that they need. So common themes about lack of provider education or cultural sensitivity include clinicians tend to know, based on the folks we spoke with, little to nothing about the interactions of gender-affirming hormone replacement therapy and insulin hormone replacement therapy, as hormones are, one seriously impacts each of the others and often can cause cascading complications, reactions, etc. So there definitely are changes in insulin management triggered by hormone therapy, but nothing that can't be handled. It just takes a provider who knows a little bit about what research has been done about this, and who also anecdotally has spoken with the many people who have initiated gender-affirming HRT and who are insulin dependent and familiar with their experiences to be able to use those to inform their clinical practice. We also found people reported the hasty attribution of physical or mental health symptoms unrelated to their diabetes or HRT, simply to those two things. As Ali mentioned before, for a lot of people with diabetes, blood sugar management is often the first thing that providers go to. And while that does influence quite a bit, and can lead to plenty of other symptoms, there are also lots of other reasons that a person with diabetes might be showing up to your clinic. And there's a similar phenomenon among trans people called trans broken arm syndrome, which is a trans person can show up to a provider with a broken arm and might be asked, well, how are your hormones? Have you checked your hormone levels? And while these things are important, it's, reducing a person's entire bodily and, mental experiences to those things can be harmful. And we find that this is compounded with people who live in both of these identities, as plenty of research on intersectionality has also demonstrated to us. And we also found generally a lack of understanding of queer and trans reproductive health, including trans medicine, as I mentioned, and a fear of seeking out medical care, either due to all of these things, having people either having experienced these things or heard about this phenomenon happening at the clinic, including being misgendered, which a lot of people mentioned as well. So on this topic, one person noted, the intersectionality of being trans and chronically ill is incredibly significant. Pursuing hormones and surgery are complicated because doctors are reluctant to give me anything with unknown side effects. Going to the doctor is a draining experience because I'm constantly misgendered, dead named, and forced to confront the realities of living in my body. But because of my illness, I have to go to the doctor frequently, so I have had to accept this feeling. I've had doctors react negatively if I've disclosed my sexual orientation. And the last major result is that dignified gender-affirming and gender and sexual minority competent care, as well as community support, is associated with positive diabetes outcomes in this sample. So we found a supportive role of social and cultural community. People spoke about how important both their trans, queer, and diabetes communities in person, online, outside of the clinic are in the material steps that they take to care for their diabetes, whether it's by receiving supplies, receiving resources, learning about patient financial assistance programs, or just emotionally connecting with other people who understand. And also we found, and as have others anecdotally, not much research I don't think any research has been done on this, but transgender people with diabetes reported lower A1Cs, which is it's the average hemoglobin levels, blood sugar levels to 2 to 3 months, which are used to gauge, to diagnose and gauge quote unquote severity of diabetes after beginning hormone therapy. And we think that that's because a feeling of comfort and safety in one's body due to lessened dysphoria or more physical and emotional comfort. But that's just an incredible finding that needs to be looked into more and underscores the importance of gender and sexual minorities with diabetes feeling comfortable enough to seek out care and for clinicians to be prepared to care for them. Being diabetic has impacted my comfort with being queer. One of our participants noted, being diagnosed with diabetes at such a young age has made me more compassionate and understanding. I'm already different from having diabetes, but I'm also different for not being straight. So quickly to conclude, the lack of clinical education and perceived bias that often affects this community adversely affects gender and sexual minorities with diabetes. Cultural community is a lifeline of emotional and material wellness, and competency is an essential component of comprehensive diabetes care. Wider scale, more representative research is needed to further understand the unique needs of gender and sexual minorities of more diverse backgrounds, and to inform policy to address these health needs. This was not meant to be a representative study, but illustrated some really important themes that as a non-binary and queer person with diabetes who was diagnosed as an adult, I've experienced much of and heard from plenty of friends and community members who have, and this is a very needed area. So hoping for some more representative work on these topics.
Great, thank you so much.
Thank you.
And we'll welcome back Leah to join in our discussion in our Q&A session. First, wanted to let Allie and Athena let you both know that there was a shout out from GK, who is a queer type 1 diabetic, in the Slido. So thank you for that representation. We're all here. A common theme that I'm hearing between both of these talks is the lack of education on the provider side about issues related to LGBTQ health, about disability, and ways that we might, this really dovetails in with what we heard from the NCD speaker about what they're trying to push in terms of making sure that we're incorporating better education into our curriculums. What are some things that you think, strategies you think that schools should take to really hammer in and incorporate these perspectives into their curriculum in a meaningful way?
This is Allie. So something that we've done at Ohio University's College of Medicine is we've brought in trans folks for panels, and more recently, because of Ohio's political climate, we have gone to virtual for that, for safety for our panelists. But we bring folks in and we say, we want to know exactly what you're going through, and we want you to tell our students as safely as we can exactly what's going on with your health. And we do as much exposure as we can, case narrative wise, to everyone in the community that traditionally has not been invited to these sorts of conversations. And I wish we had more policy ingrained into it, where it was like not just driven by folks like myself, faculty like myself, and other folks in the community that work at the university, but we've got a lot of work to do. But people's stories are so important.
I think also, I mean, people's stories, but also as we move forward, and I think as doctors and healthcare professionals start becoming more diverse themselves, we're going to see better care in these areas when the representation is on both sides, and that it's not just a white male that's the doctor, but that both sides have marginalized identities.
Mm.
Yes, I very much agree with both of you, Allie and Leah. I would also say that this didn't come up as much in this study, but something we hear frequently with people with disabilities and chronic illnesses, especially complex chronic illnesses, is a long length of time to diagnosis and a pattern of not being believed, especially, if you have identities that doctors are trained to take less seriously. I don't think it's intentional, but I think that with complex chronic illnesses or complex interactions that we don't know much about, like HRT and insulin, for example, even the best intentioned physicians who are trained to always know the answer or to always make a decisive remark based on how a patient is presenting will just miss this connection. So I think that including being okay with saying, I don't know, but I hear what you're going through, and I'm committed to figuring this out with you as a provider makes such a difference. And it's okay to not know. I think no one we're speaking to in these studies is expecting or demanding that a physician knows, but they want to be believed, they want to be taken seriously. And maintaining a curious and respectful approach, and understanding that there might be a new connection that just hasn't been researched very much yet, or that we haven't figured out yet, could be going on. The patient knows their body well.
And I think even before what Athena said is like, when healthcare professionals have been around disabled people before, it's really clear. When they have never been around a disabled person, we notice things like they're not believed, they don't even make eye contact with them, they don't talk to the disabled person, they talk to anyone else in the room. So some of these like things that come before even the diagnosis part of it is really, really important as far as just having been around disabled people and being comfortable with different types of bodies.
Yeah. Yeah, I think that definitely goes back to your earlier point, Leah, of as we increase representation within the medical field of having people with that lived experience, then people see what that looks like outside of just that one medicalized encounter, and what is a whole life look like. So I absolutely think that's so important. Just wanted to call out one of the comments from the chat. Anonymous said, as a trans diabetic person who identifies as disabled, I really resonate with this. I struggled a lot to find fully supportive healthcare providers, but once I found actually supportive people in my community, I felt much more empowered to take care of myself, and all of my health outcomes improved. Yeah, so yeah, again, really underscoring that importance of having having that healthcare team that knows what their patient is going through, or is willing to take those steps to learn about it. That does bring up a thing that has come up in my mind with previous conferences, is that oftentimes I feel like we're preaching to the choir, and that the people who come to this conference who are engaged in this session, we already know that these things are important. How do we get this message out to that broader audience? What else can we do other than, like we said, increasing representation and having these mandated things like the NCD is recommending? What are other things that you might recommend?
I think that's really hard and something that we face all the time as far as, preaching to the choir. And I think constantly getting it out, and the more it becomes part of, even if it is the choir's narrative, then it seeps through to other people, right? If that's a constantly reinforcing it in people's brains that we are aiming for a better future for people. I don't know that I have the exact answer, but that's one way that we look at it.
And this is Allie. Something that I think about a lot is I like to show up in places that are very medical and show up and talk about the work that I'm doing, and talk about disability, and talk about, this research with Athena. By the way, we have a study right now, a follow-up study that we're doing. And so we are interviewing folks. So if anyone knows of anyone that is GSM and has diabetes, send them our way. We have funding for that work as well. But I like to show up and just say, well, what about this? And what about behavioral medicine? And what about quality of life? And the thing that we see a lot also in diabetes, and of course in disability, which is why it's so important to think about them under that umbrella of, the overlaps, and finally accepting that diabetes is a disability, is everything is very cure-based and in diabetes. And the focus that I think about as a disabled queer health psychologist is like, well, I've had this for 30 years, and how are other folks going to even access a cure, and how are we going to live better quality of life? So that's what I'm always thinking about, and that's why I'm so passionate about policy and the national and international work I do. It's like we have to keep pushing and getting the work out. And so I'm always like, when I just came from a conference in Chicago at Society of Behavioral Medicine, and I always tell people, hey, if I already said this, you let me know, but I'm going to give you my spiel again about disability and diabetes, or I'm just going to keep going, so I just think, we have to just keep networking like this, and places like this are great, to even folks connecting that may not have known each other before. This is my first time attending, and I'm seeing so many folks. I'm like, I'm definitely going to reach out after and, keep talking about the important work we're doing.
Great.
This
Yes.
is Athena.
Go
Oh,
ahead.
sorry. I have a
Go
quick
ahead.
thing to add. As a PhD student right now, I went back to grad school after years of years in between bachelor's and now. And I just sometimes am frustrated by how siloed everything is and how inaccessible to people outside of academia it is. And you have to be writing in certain ways and certain things to get tenure and all that. But for those of us who are in academia and research, I think trying to find outlets outside of academia, and it's a great way to practice communication too. But if you can get on a podcast, write a public facing journalistic piece, if social media or art is your thing, use that, but find ways that are outside of for those academics to try to get it out there. It can be hard, but it helps reach a wider audience.
Absolutely. Yeah, I think, Allie, you touched on this at sort of part of the beginning of your talk. There are many people with diabetes that don't consider themselves being part of the disabled community, and they don't see that connection between what they're experiencing and need for accommodations and disability. And I think by, like what you mentioned, Athena, making sure that we're disseminating this broadly to a broader audience, shifting people's mindsets about what does disability mean? How are we all interconnected? What are our shared experiences? Myself, growing up with kidney disease, I never thought of myself as being disabled, but it was really through the work that Pete was doing when he was founding this organization. It really opened up my mind about all the things that we share in common across different types of disability, and the struggles and barriers that hearing other people's stories has really taught me. I have one more comment from the chat. Eli Harkin says, I also feel like it shows the culture needs to change. If I, as a disabled physician, express not knowing, some people will trust me less, even though it's a better route for understanding with patients. And so, yeah, I think finding ways that we can challenge the system, I think is really important. We're heading into our break. We have until 9:50 is the end of the next break, but thank you again, all of you, for the outstanding talks. There are definitely still a bunch of comments in the Slido. So if you have a few moments over the break, you might be able to go and see if you can respond to some of those. And again, the Slido is a great place to connect and meet other people that are here at this conference as a virtual kind of town hall meeting space. Yeah, great. All right, so we'll reconvene at 9:50 for our next session number 3. All right, thank you, everybody.
Thank you so much.